I'm Marcia McDougall from NHS Fife, and I'm going to be talking today about fluid stewardship. This is our bridge from Edinburgh to Fife, the fourth bridge. My disclosure slide. What is fluid stewardship? Well, basically it's giving fluids carefully, and it is trying to standardize as much as possible around the use of fluids. So the types of fluids we use, fluid balance charting, and other systems such as pumps and lines around fluids. It's a whole hospital approach. Why should we do this? Well, we know that in medicine, if there's a lot of variation, then there will be suboptimal outcomes, because it means that lots of people aren't doing things properly if everyone's doing things differently. The benefits are mainly to patients in avoiding harm, but there are benefits to prescribers, nurses, and managers as well. This is the National Confidential Inquiry into Perioperative Outcome and Death from 1999 in England, and it basically showed that there was quite a lot of morbidity and mortality associated with IV fluid prescription, particularly elderly patients, and they showed that new doctors had poor knowledge and skills. So up to 20% of patients getting fluids might suffer harm, and that's really quite a lot of harm, which we should try and get rid of. We looked at mortality in NHS Fife, and we found not a dissimilar amount of mortality and morbidity. There was poor fluid balance chart completion, and it was again the frail elderly who were coming to harm from too much or too little fluid. Senior doctors weren't very much involved in this, and if patients were on a fluid restriction, they often got very little fluid at all. This is a slide from Professor Lobo. So on either side of normovolemia, you can have bad things happen to the patient, and this can cause pulmonary edema, peripheral edema, and ileus, and also problems with the kidneys. And then on the other side, you can get hypotension and acute kidney injury. So it's important to aim for normovolemia. And these are just some pictures to illustrate that. If it hasn't been lost, then we shouldn't be giving it, because you're just going to put it in the wrong place. Of course, we can be too dry, and that can result in AKI particularly. So a quote from Professor Dilip Lobo: the right amount of the right fluid at the right time, and that's the basis of fluid stewardship. Which fluids should we use? Well, it depends on why the patient needs fluids, and we split that into maintenance, replacement, and resuscitation. There's not a lot of literature about maintenance fluid, but Niels van Regenwortel has been addressing this with 2 trials, and he found that using a sodium-rich maintenance fluid, such as a balanced solution or sodium chloride, was associated with a more positive fluid balance than if you use a low sodium maintenance fluid. And he also found that using a low sodium fluid did not cause harmful hyponatremia. The NICE guidelines, which we follow, suggest using a low sodium fluid for maintenance with glucose and potassium, and this is the fluid that we use, but that's for adults only, and my talk is based on adults, not pediatrics. There are other maintenance fluids available as well. We have got quite a lot of data on this over the time of our guidelines, and we have not found an increase in harmful hyponatremia, and we have found a decrease in acidosis over the last 8 years since the guidelines were introduced. Replacement: should we use saline or should we use balanced solutions? Well, there's a few trials out there. The most recent ones are Salted and Smart, and those show some reduced risk of kidney events. And then there are some retrospective studies of saline versus balanced solution as well. The the balance of these is towards using balanced solutions rather than saline. Saline 0.9% really shouldn't be called normal. It's not physiological. There's too much chloride, and it's also poorly excreted. And there's some elegant experiments by Lobo and Hahn about giving volunteers 2 litres of sodium chloride, balanced solution, or 5% glucose. And a lot of the sodium chloride is still retained in the body after 6 hours, whereas less so with the balanced and the least with the glucose. It's worth looking those trials up. Salt is recommended at this amount by the WHO. We have too much of it in the UK and probably in the rest of Europe. 1 millimole per kilo is the recommendation per day, and that's 4.6 grams for an 80 kilogram man. 1 litre of sodium chloride 0.9% has 9 grams of salt in it, and that's a lot of salt. There are some meta-analyses about saline versus balanced solutions as well, and they favour the balanced solutions in most of them, apart from there are some that just say there's little difference. The trouble with all of these trials is that they are comparing, for instance, giving 2 litres of saline versus 2 litres of balanced solution. In reality, what happens is that patients get 6 litres of saline or 4 litres of saline, and that's not studied in trials, and harm is more likely in that situation when people are getting far too much 0.9% sodium chloride. Resuscitation, we use a balanced crystalloid. If you do give saline, then you should avoid giving litres and litres and litres of it. Obviously, blood is sometimes required, and in our hospital we occasionally use colloid in ICU or theatres, but it's not widespread. Fluid stewardship has benefits to prescribers as well, and that's mainly in standardising the education as well as standardising the fluids. Fluid prescribing traditionally was done by juniors with very little support, and they would get a blank fluid chart to fill in. They didn't know very much about it, and their confidence was low, and that was shown in a survey in Edinburgh in 2011. This is the kind of chart that we might have had in the past, and you can see all the saline that's been given to this patient, and indeed he got 6 litres of saline in 3 days, which is far more salt than he should have got, and he hardly got any potassium, and he got too much fluid as well if you discount the resuscitation fluid. We're trying to get away from this overuse of saline and overuse of fluid. Anaesthetists are not immune from prescribing either, and this is an interesting study from the BJA which showed that for a similar colorectal procedure, a 4-hour procedure with 400 mils blood loss, patients in different hospitals received anything between 700 mils and 9.7 litres of crystalloid, and the predictor was the anaesthetist rather than the patient or the surgery. So it's important to have a guideline to follow, and this is our guideline, which is adopted from the NICE and the Gift to Suck guidelines. Again, it's an adult guideline, and we shouldn't use low sodium fluids in children. We need to standardise the approach to prescribing, and we've done this by having these questions. You need to assess the patient, ask if they need fluid, why, is it for maintenance, replacement or resuscitation, how much and which fluid. And our guidelines also address these issues in a bit more detail. What should we do? Well, the NICE guidelines say this is what you require for maintenance. And if we follow this, then it makes a difference to a very small person and a normal size person of 80 kilos. So if we give a 40 kilogram man 2.4 litres, he's rapidly going to get overloaded and run into problems. This is our prescription chart, and it has part of the guideline on the chart. having it in front of the prescriber, and this makes a big difference. On the other side of that chart is the prescription and balance chart. We have a stop and check at 2 o'clock for the nurses to see if there are any problems going on, such as inadequate intake or excess loss. Education is really important, and this is probably what I spend most of my time on now for nurses, junior doctors, nurse prescribers and consultants. And we have an e-learning module and also practical sessions to do with fluids. This is a recent study of attitudes to fluid prescribing in our hospital, and you can see that the vast majority of those juniors agree that they've had good training, they've got enough information, and they're confident in prescribing. Some of the comments they were making are also quite gratifying, but we still have a problem with not enough senior doctors being involved. There are benefits to nurses in having good fluid stewardship as well, because there's better patient care, they get education on fluid balance, and there's standardization of all of these things, which makes their life much easier. This is just a picture of some of the fluid storage in one of our wards. We have these posters up in the wards, and that helps with fluid balance charting. We have benefits to managers as well, and I've put this last because I don't see saving money as the primary issue here. Better patient care is definitely more important. However, we did save quite a lot of money once we started doing this work. This shows our fluid use over the time from when we started the work in 2009, issued the guidelines in 2012, and you can see that our saline use has dropped right down from 6,000 litres a month to about 1,500, and it's stabilised at that. And we're using more of the maintenance fluid and more of the balanced electrolyte solutions. Along with the saline use dropping, we've done a study, and it's shown that acidosis developing in hospital in patients who've received fluids has dropped in line with the reduction in the use of 0.9% saline. This shows that the litres per occupied bed day has also dropped, so the overall fluid use has dropped by about a third, and that saved us almost £100,000 per year compared with January 2009. We now have a national programme in Scotland based on the work in Fife, and this aims to standardise practice across Scotland to improve patient care, but also to try and standardise education in the universities. Saving money, again, is bottom of the list, but no doubt has some leverage with some of the managerial staff. The Scottish Government has provided quite a lot of funding for this project, and most hospitals in Scotland now have either a fluid nurse or a QI member of staff for fluids. We have regular meetings, and we can keep an eye on this with national pharmacy figures. We're using nationally agreed guidelines and teaching strategies, and all hospitals in Scotland are taking part. Just finally, I'm going to show you a few graphs showing that we are using, this was in 2016, we were using the most fluids with potassium, and these are all the different hospitals in Scotland. And now the percentage on the left is the percentage of crystalloid with potassium supplement in it. So our amount has gone up from 12.4 to 19%, and in Scotland it's gradually increasing. You see some of the lines are going up the way. This is from 18 to 20, but many of the hospitals are not quite on board with all of this yet. Similar with saline, we were using the least, and now the amount being used in Scotland has dropped from 50% to 40% since 2016. and we are using 75% of our bags are litre bags in 2016, and in 2018 that's gone up to 85%, and in Scotland it's gone from 40% to 50%. So we are making a difference, albeit gradually. And this is the message for fluid stewardship. Please send any questions to these email addresses. Thank you.